Results are amazing. All right, to continue on this topic of advancement in Profilo, we have a panel discussions on the Profilo 2.0 technique using Profilo for under eye and forehead. We are certain you always have patients asking you about the treatment for upper face after you've done Profilo for them with the BAP technique. And now we would like to invite our three panelists to discuss about this topic with us. And now we would like to welcome back Dr. Matilda Weni, who will share her experience and moderate these sessions for us. Dr. Ellen Cabrera, dermatologist from Philippines, that will speak about the anatomy of the areas and her experience. And Dr. Nurul Ain, aesthetic physician from Malaysia, who will explain why she introduced this technique in her clinics for her patients and her experience. Dr. Allen is a board-certified dermatologist of Philippine Dermatological Society, a fellow member of Philippine Academy of Clinical and Cosmetic Dermatology, continuing in practice of procedural dermatologies, a key opinion leader for Allegran Aesthetics, and medical director and president of Skin Click Ventures and Facial Studio MD Clinic. She has been speaker and KOL, experienced injector since 2003, botulinum injections and soft tissue fillers, has been lecturing on injectables since 2008. And Dr. Nurul Ain Abdullah, who have earned her medical degree from the National University of Ireland and an MSc in Aesthetics, Anti-Aging and Regenerative Medicine from UCSI Malaysia. In 2014, she founded Elaine Clinic, focusing on achieving natural look results through face sculpting with dermal fillers and improving skin quality with injectable treatments. So, without further ado, over to you, doctors.
I think this one.
Hello, Dr. Nurul, Dr. Allen. Thank you to joining with us today to discuss about the Profilo 2.0. This is an interesting technique, right?
Yes.
And I'm sure that many of our colleagues curious to listen to our experience for Profilo 2.0. And first, for Dr. Nurul. Dr. Nurul, you've been using Profilo since 2020.
Yes.
And at the beginning, we only used Profilo with 5-point BAP technique.
That's
on
right.
the mid face and the lower face. And now, can you share with us your experience about the Profilo on the upper face?
Sure, okay. So maybe I'll get here now and start my presentation?
Yeah, you can start now.
So firstly, a lovely afternoon to everyone, and thank you so much, New Asia, for having me today. It's indeed a pleasure to even share the stage with Dr. Matilda and also Dr. Allen. So I'm going to start the topic of Profilo 2.0. So, not too long ago at IMCAS Bangkok, I shared about eye-opening rejuvenation beyond fillers. And what I shared was the Dunning-Kruger curve with regards to periorbital rejuvenation. So for those of you who does not know what is the Dunning-Kruger curve, it is the relationship between our competence and also our self-assessed skills. So for us in medical aesthetics, it's about our procedures. There is that one peak there, which is Mount Stupid, which means that you have low competence but high confidence. In my case, it was at year 3 as I enter into aesthetics, where I thought that tear trough hollowness can be addressed with tear trough fillers or HA fillers alone. But of course, boy, I was very, very wrong. And it took a downturn of the curve to learn, and now more than 10 years, I am still here, and we are all still here learning about how to treat tear trough area. And then I saw this article recently, and we can all see that lump under her eyes, right? And we know that she is a very famous Hollywood star. So I'm sure she has the access to the best of the best plastic surgeons or even doctors, right? And yet, we still see that lump under the eye. So what does it mean? It means that it is not an easy area to address, And it is a good reminder to also all of us that the periorbital area, or namely infraorbital area, is a complex treatment to perform for us. So, when we talk about complexity, what are the adverse events that we can face with tear trough fillers? Number one is the Tyndall effect. That's the dreaded one, where we can see the bluish discoloration is underneath the skin. And we know that is due to the superficial placement, and it is due to the light scattering on the under eye skin. Then we have the contour irregularity. And why is that so? Because of the complexity of the retaining ligaments and also the orbital rim and also your orbicularis oculi muscle as well. So it's very hard to be able to get in between up and down and just try to smoothen out the whole area. And then you have the persistent edema. Why do we get that? In some of our patients, if they have allergy rhinitis or history of sinusitis, you know that their lymphatic drainage is already so compromised. And if you insert and you inject more product into it, it will be more compromised, and that will result in the persistent edema. And then, of course, you have the inflammation and the granuloma, and you don't even mention about the filler migration. And what is happening nowadays is the overfilled tear trough. So people are trying to pump in more and more HA fillers until you lose the natural beauty and the concavity that you see in the eye. So I was very interested even just a few days ago when Dr. Giovanni Salti mentioned about him not injecting tear trough fillers with HA anymore. And I think I see a lot of expert injectors are also moving away from using just HA fillers alone. But then, are we really moving away from HA? And the curious part of me, I tried to look up some publications and I stumbled upon this very interesting article. So in this article, it is looking at the efficacy and safety of hyaluronic acid tear trough injections as a systematic review and also a meta-analysis. So we wanted to see all the efficacy and also the safety profile. And the meta-analysis comprised of 31 reports, and that is over 2,556 participants. And the pool overall satisfaction rates from patients is actually more than 90%. So that is still quite significant. And with regards to the side effects, the much reported was just the swelling and edema and bruising, which was about 20%. And the part where we didn't really want, which is the Tyndall and also the irregularity, the lumps, that was just between 5 to 7%. So the conclusion was that it showed a low risk and complication rate and a high satisfaction rate in tear trough area, which means that we are still going to use HA fillers at the tear trough area, but maybe HA something else, not a crosslink HA. And so that is why we come to Profhilo 2.0, because we know that for the past few years, we have been using Profhilo for our mid-phase and lower phase with the 5 points BAP technique. And now we can use it for the periorbital area or infraorbital. We can also use it for the forehead and also the temple area. So why Profhilo 2.0? Because we do have patients who are someone who is aversive towards HA fillers. We have patients who also do not want any neuromodulators for the forehead area. And so people are moving towards a more natural and subtle results. And that is why we have now Profhilo 2.0. So with regards to injection anatomy, I will invite Dr. Allen to continue.
Okay. First and foremost, I'd like to thank, for inviting me, and good afternoon to everyone. I hope I'd be able to share something in your practice. Now, yes, I will be discussing anatomy, which I think is an integral part to have a safe and effective treatment for injectables. Now, when we talk about anatomy for injectable, or what we call injection anatomy, it is quite different from surgical anatomy, wherein through dissection with surgical anatomy, you can actually see the vital structures right before your eyes. Whereas with injection anatomy is being able to anatomically see the surface landmarks on the face and the safe depth of where the needle should be. So it's really knowing the layered anatomy from the skin down to the skeletal structures, focusing on vasculatures and focusing on danger zones. So let's begin with the forehead anatomy. Now, over the years of studying the crosslink HA, we have found out, or we learned, that the safe plane for injection for the crosslink is really the loose areolar tissue, where that of the Profilo or the hybrid cooperative complexes is the superficial fat compartment. So just reviewing the layers of the forehead. First, we have the skin, then we have the superficial fat compartment. Before, we used to think of the subcutaneous fat as one whole sheet. But in 2007, Dr. Rorik and Pesa reported that the fat, the subcutaneous fat, is arranged by compartments. Now, once we lift off the superficial fat compartment, we have what we call the galea. Now, this is, if we will talk about the scalp, the skin, the connective tissue, which is the superficial fat, and then we have the A for the aponeurosis, it is really the galea aponeurotica. Now, the galea is really this mass on the midface, but once it goes to the forehead, it becomes the galea aponeurotica that splits into two laminae to envelope the frontalis muscle. And so it is fused together on the forehead. You have the galea, frontalis, and galea. Okay, once you reflect it off, then you have your periosteum. So here you could see on the blue, the white here, is what you call the loose areolar tissue, which is the safer plane of injection, and then the periosteum covering the bone. Now, going to arterial anatomy, this is actually the danger zone, okay? Because in the forehead, you have two main arteries of the forehead. You have the supraorbital and the supratrochlear artery, branches of your ophthalmic, and coming from the internal carotid artery. Now, the supraorbital artery, when you try to map it on the face, I always ask the patient to look in front, and then you stare in front and map it out from the medial limbus of the iris. You go up about 1 centimeter from the mid-brow. There is an ostia or a notch. Now, from here comes out the supraorbital artery. It starts very deep on bone, and then once it reaches the mid-forehead, it becomes more superficial to supply the superficial layers of the mid-forehead. It forms anastomosis with the superficial temporal and the supratrochlear artery. Now, the second artery is the supratrochlear artery. Again, it starts on the bone, and then once it reaches mid of the forehead, it becomes superficial to supply all the superficial layers of the mid-forehead. It forms anastomosis contralateral to the supratrochlear to the superficial temporal artery. Now, going to the infraorbital area, since we are already in the vasculatures, the most important thing there is the infraorbital artery. To be able to map it out, what you ask is to ask the patient to look forward, and then you map it from the medial limbus of the iris, again, 5 to 8 millimeters below is your infraorbital foramen, where your infraorbital artery comes out. So we have to know that this infraorbital artery has minute branches that forms anastomosis with your facial artery, your angular artery, and that we should remember that the angular artery has a direct connection with your dorsal nasal and the supratrochlear, again from the ophthalmic, from the internal. That's why different journals, they have they always say that there is a unique connection of the external and internal around the eyes because of anastomosis. Now, when we are doing the infraorbital area or hollowing, I start by injecting on the blue point. Okay, so as we travel up to the infrabrow, we encounter the several layers like the skin, and then you have the superficial fat compartment, and then you have the SMAS. The SMAS is made up of fibromuscular layer, made up of fat cells, collagen, elastin. This connects the mimetic muscles into the skin. And then once we reflect off the SMAS, then we have the muscle. Once we reflect off the muscle, we have the deep fat compartment, which we call the SOOF, or the suborbicularis oculi fat. Now the SOOF, there is what you call the medial SOOF and the lateral SOOF. The medial SOOF starts from the medial limbus of the iris. It goes up to the lateral canthus, while the lateral SOOF from the lateral canthus, it goes up to the edge of your orbicularis oculi, which acts as a gliding plane for EC contraction. Now, another important structure in the infraorbital area is your orbital retaining ligament. So the orbital is a true ligament, an osteocutaneous ligament, wherein it originates from the periosteum and inserts into the skin. Now, it runs the whole diameter of your orbital rim. Medially, it is very adherent. It originates from the anterior lacrimal crests, and then it starts like a single lamina in the medial part. Once it crosses through the medial limbus of the iris, it becomes bilaminar, and then it has a very adherent attachment called the lateral orbital thickening or the lateral canthal tendon before it goes around the superior orbital rim. Now, the orbital retaining ligament also delineates the orbicularis oculi muscle into orbital and palpebral. So the orbital is for the voluntary opening, and the palpebral is for the blinking or the involuntary reflex. Now, all these orbital retaining accounts for the surface landmark. Medially is what you call the nasojugal fold, laterally is called the palpebromalar groove, and the mid-cheek groove is the zygomaticocutaneous ligament. Now, as we go up to the inferior part of the medial canthus, we lose all the fat compartments so that we only have the skin, the muscle, and the bone. And we should remember that the muscle is actually stuck on the medial palpebral wall because that is the origin of your orbicularis oculi muscle. That's why when we're injecting, we are really injecting subdermally or intramuscularly. That's why we have to inject minutely in this area. Okay, for my infraorbital technique, I followed the study that we are conducting right now. We started, some of the doctors started January. Well, I just started just last May. We are trying to check the adipogenesis effect of Profhilo 64 milligram per 2 ml. So this is the protocol that I followed: 0.1 ml on the medial SOOF, and then 0.1 ml on the lateral SOOF, 0.1 ml on the infraorbital subcutaneous, and 0.1 ml on the lateral orbital subcutaneous. So this is how I do it. I use a gauge 23 needle to create a hole, and then I use a gauge 25 cannula, and then slowly as I reach the suborbicularis oculi fat, then I start injecting. So this is really sped up twice, but in actuality it is very, very slow. I try to make it very slow. Now it's 0.1 and 0.1 for the medial SOOF, and then later on, you will see that I will go down and inject 0.1 on the infraorbital area. Okay, I usually only use gauge 25 because if you use lesser than that, they can there are reported cases of intravascular occlusion or penetration because you have poked the blood vessel. Now, the same thing is done on the other side, so I won't play it anymore. Now, for the forehead technique, Dr. Nurul will share her technique. Okay.
Okay, so we've seen the infraorbital area. Now we're going to go to the forehead technique. So for the forehead technique, we can divide it into two. You can categorize it whether it's a smaller forehead or a larger forehead. The difference is actually in the amount that you're going to use. So if it is a smaller forehead, you can use just one box, which is 2 mils. So you will divide it into the forehead area, 1 mil, and temple, and then the other side is also 1 mil. But if it is a larger forehead, then you will use actually 2 mils per side. So in terms of the technique that we're using right now, it is based on the study that was published by Dr. Coimbra from Brazil. And in this study, he shows that there's safety and efficacy for the forehead and also temple skin rejuvenation with Profilo. So how do we do it? We firstly mark out these areas. So there will be a total of 4 boxes. So the 2 boxes are at the forehead, and the other 2 boxes will be at the temple area. And in terms of the forehead, we will use 0.6. So in terms of the border, it is the superior border will be just 1 centimeter below the hairline, and then the medial border, it will be the midline of the forehead itself. The lateral border is the temporal crest, and the lower border will be just above your eyebrow. And insertion point of the cannula will be just slightly lateral to the temporal crest line. And what you will need to do is that if you want to make the patient more comfortable, because I have tried myself without anesthesia, it can be a bit of a discomfort. So we will inject local anesthesia first, 1% of just lignocaine. And in terms of protocol-wise, you will still do the same, so 1 month apart and 2 treatment sessions. Okay? In terms of using cannula, the size can be 22 or 23 gauge cannula, 40 to 50 millimeters. In terms of the temple, so the area will just be at the zygomatic arch, just slightly above. So it's something like what we've watched just now as Dr. Elman was showing the area he injected the Aliaxin SR. So it's a similar landmark, and the amount that we deliver is 0.4 mils. So you will have like the 2 lines, and you will distribute 0.2 and 0.2. And the plane of the product that we're going to place is actually just superficial subcutaneous area. And again, is 2 treatment sessions, which is 30 days apart. So in terms of the video, this is just a very speed up video of the surface marking. So you can mark the temple area and also the forehead, okay? And then in terms of the anesthesia, so you can deliver about 0.1 at the entry site. And in the forehead, you can give 3 injection points of 0.15 mil per area. And after you've injected the area, then just massage it a little bit. Okay? And you would do the same also at the temple area. But at the temple, you will give only 2 injection sites. So you can use a 21 gauge needle to introduce. And in this case, I'm using 23 gauge cannula, 50 millimeters. And at the forehead, you will deliver 0.6 mils. For the temple, again, 21 gauge cannula, and then you will deliver about 0.4. So that will give a total of 1 mil per injection site. So if you see that, that is just immediately after, and you do get a little bit of the irregularities, but that is actually normal. And expect to tell your patients that the downtime is anywhere between 6 to 24 hours. If you put the more amount, then of course the downtime is going to be more. So I generally just tell them anywhere between 48 to 72 hours so that your patients don't scold you for the longer downtime. So, patient selection, I'm going to invite Dr. Matilda now to share about patient selection.
Thank you, Dr. Nurul. if we talk about the patient, if we talk about the potential effect of any kind of treatment, whether it's EBD or injectable, what we should remember is patient selection. Identifying good candidate as well as a bad candidate is very crucial. So, who is the best candidate for Profilo 2.0? On the infraorbital,
There's an echo.
the good indication or good candidate, number one, patient with hollow. And then thought skin tissue under the eye, patient with thick skin, and also patient with mild eye bag. But don't do the Profilo 2.0 on the infraorbital if your patient comes with large eye bag, fluid retention, thin skin, and also patient with malar mold. And for me, at my clinical experience, precaution, for patients who have previously received theatral filler before with crosslink HA, there is a potential for prolonged swelling. And the Profilo 2.0 for forehead, there is no contraindication. There's only good indication and bad indication. The good indication is patient with hollowness on the forehead, and then patient with forehead static wrinkle, patient with uneven skin texture. But don't do the Profilo to forehead or to any area of the face if patient allergic to HA and patient with unrealistic expectation. We can see clearly from this image, this is a face tone. This is a bad indication or contraindication for Profilo 2.0. Face tone is cascaded by the laxity of the skin and laxity of the orbicularis oculi around the malar eminence. It's different from festones is different from malar mons. Malar mons is chronic swelling on the malar eminence. And you also have to differentiate between the, this is a hygroscopic swelling. This is a physiological effect when natural action of hyaluronic acid is injected into our skin. This hygroscopic swelling is different from edema, where edema is unwanted end result if we do the filler or Profilo injection under the periorbital. And now we go to the clinical case session. Dr. Ellen will start the clinical case.
These are the before and after photos of my patients. Usually the indication is infraorbital hollowing with crepiness or multiple creases under the eyes. So this is 2 treatments, 3 months after the second treatment, and you can see very good, remarkable results. So there. Okay. Now, this is another patient of mine, which I have combined with the crosslink HA on the mid-face to give the structural support, and then did Profilo on the tear trough. Again, this is the before and after 2 treatments, 3 months after the second treatment. So on profile view, there. Now, for this one is actually my post-op of my forehead, actually to treat the concavity of the forehead, at the same time the hydration of the skin. And on profile view, you could see very mild lifting of the brow. Okay. Now, for Dr. Nurul.
So I'm going to share firstly forehead and infraorbital area. This is after 2 treatment sessions, 1 month apart, and there's like the slight improvement under the tear trough area and also the forehead lines. And this is a patient of mine who had steroid injections injected into the forehead area due to her psoriatic plaque. And we actually used the Profilo to inject 1 month after, just to simulate. And 1 month after, she noticed that it's much more smoother. And these are all the studies that we enrolled for the multi-center study for the infraorbital Profilo 2.0.
Yes.
And these patients are all above 50. So in my patients, when it comes to Profilo 2.0, I prefer in someone slightly older with skin laxity. But as Dr. Matilda has mentioned, just make sure that it's not, the patient does not have severe eye bags. And this is also another patient of mine who's had improvement of the under eye as well, just 2 months after the second session. So now I'll pass to Dr. Matilda.
Okay, I have two patients. This is my first patient. She came to my clinic with a concern of dark circle. And then I injected. This is 1 month. This is 1 month after first injection. And this is 1 month after second injection. As you can see, there's impressive improvement on her periorbital areas. The skin look fairer and then less wrinkle. And also, we can see slightly volumizing. This is my second patient. She came to my clinic with a concern of hollowness under her hollowness on her under eye, as well as hollowness on the forehead. I already offered her filler injection on the infraorbital area and also the forehead, but she preferred not to inject it fillers, and I convinced her to inject it the Profilo 2.0. This is the baseline. This is 1 month after first injection. This is 1 month after second injection. As you can see, there's improvement, quite impressive improvement. The skin looks more fairer, less wrinkle, and also you can see a slightly volumizing effect under her periorbital. And for the conclusion, Profilo 2.0 is an alternative to cross-link hyaluronic acid for high-risk area, for example, forehead and infraorbital. Profilo is not just a skin booster, it's a bioremodeling agent that comprehensively improves the extracellular matrix, different from derma fillers and botulinum toxin treatment. Profilo 2.0 represents a game changer for patients seeking natural outcome result. And then Profilo 2.0 introduced a novel approach to regenerating the infraorbital and upper face area. The Profilo 2.0 is safety and recommended to use cannula technique. For Profilo 2.0, it is important to choose the right candidates for optimum result. Thank you. Dr. Alan, Dr. Nurul, do you have any additional?
No, you wrapped it up
Okay.
nicely. Thank you very much, Dr. Matilda.
Thank you. I give back the stage to MC.